Hi everyone, I'm Dr. Naina, mentor Study MRCOG, branch of Study Medic team. So in this video, we'll be discussing on the KickStart series regarding the antenatal module. The topic for today would be hypertension in pregnancy. So never give up till the day comes of your success. So coming to about the antenatal module, the topics which needs to be covered under the antenatal module for the Part 2 MRCOG exam preparation are preterm labor, preterm pre-labor rupture of membranes, hypertension in pregnancy, antenatal care from the NICE guidelines, multiple pregnancy from NICE guidelines, monochorionic twins from the Green Top guidelines, amniocentesis and chorionic villus sampling from the Green Top guidelines, antepartum hemorrhage from the Green Top guidelines, placenta previa accreta from Green Top guidelines, vasa previa from Green Top guidelines, blood transfusion in obstetrics Green Top guidelines, reduced fetal movements from Green Top guidelines. It's quite an old guideline from the GTG. Even investigation for the small for gestational age babies, it's also quite an old one. Late IUFD and stillbirth from the GTG. Obesity and pregnancy, it's not very old, it's pretty new. Obstetric cholestasis, it is one of the newest guidelines from the GTG. RBC antibodies. Antenatal corticosteroids is also one of the latest guidelines from the GTG. Cervical encirclage as well as anti-D. So of these guidelines, it is actually a mixture from both the NICE guidelines as well as the GTG guidelines. So the first preference for Part 2 MRCOG examination is that we need to be thorough with the guidelines, the Green Top guidelines as well as the NICE guidelines. And then next would be to go through the TOG articles, which are the relevant TOG articles, as well as the last, especially for the last 3 years TOG articles. And if for a particular topic, the guidelines are not available, then we may need to go back even before 3 years also to look for that respective TOG articles. Another important area is the scientific impact papers, wherein certain papers are really good and they're a good source of questions for Part 2, for especially the SPAs for Part 2 MRCOG examination, and even good practice papers. So of these guidelines which I've mentioned here, comparatively newer guidelines are the cervical encirclage, antenatal corticosteroids, obstetric cholestasis, then obesity in pregnancy, preterm labor, PPRM, as well as the amniocentesis and chorionic villus sampling. So we can expect more questions from the recent guidelines. Now, what are the tips and tricks for Part 2 MRCOG examination? So definitely it's guidelines based. And it's not enough that we are theory thorough with those guidelines. We need to have a clinical applied knowledge of all the guidelines. And each and every line of these guidelines are important, especially from an EMQ, that is the extended matching question perspective. We need to be thorough with the flow charts, because those EMQs are usually tricky questions and very confusing, as they have got very close options and lot of options are available for each single STEM question. And be thorough while you thoroughly read the STEM question and analyze each options. And not like you should go through the first options first and then go back to the question. Always read the question first, analyze it thoroughly, understand it thoroughly, and then you work upon by excluding each of the options. And for the EMQs, very important area for the source of questions are the flow charts, which are given at the back of the guidelines or towards the end of guidelines. Also, the tables as well as figures, which are given in the Green Top guidelines, NICE guidelines, as well as tables of the TOG articles, also very important. Now, we shall discuss from the topic proper, that is a hypertension pregnancy. We shall discuss few questions, some of the SPAs as well as some EMQs, and try to analyze through the guideline. That is a hypertension pregnancy. It is a NICE guideline. The first question, which of the following drug is indicated for prevention of preeclampsia? Now, so basically the classification of the hypertensive disorders on pregnancy goes like either it can be essential hypertension or chronic hypertension. In that case, the onset of the blood pressure a high BP, that is more than 140 by 90 millimeters of mercury, will be either detected pre-pregnancy, or if it is during pregnancy, it should be less than 20 weeks of gestation, and also it should persist more than 12 weeks in the postpartum period. It may or may not be associated with proteinuria. And the second scenario can be like hypertension with superimposed preeclampsia. So already there is a diagnosed case of chronic hypertension with superadded features of the preeclampsia, like new onset proteinuria or any new onset variation in elevated liver enzymes or increasing creatinine or oliguria or any other symptoms can happen after 20 weeks of gestation. The third thing is preeclampsia, that is blood pressure which is more than 140 by 90 millimeters of mercury, and its onset is first after 20 weeks of pregnancy, and it resolves less than 12 weeks postpartum. It may be associated with the proteinuria for the definition of preeclampsia. But the new guideline states that even if proteinuria is not there, still, if the BP is more than 140 by 90 millimeters of mercury, along with that, if there is any evidence of end organ damage, like any kidney involvement, liver involvement, or CNS involvement, or any fetal involvement, in that cases also, we can classify it as preeclampsia. Another entity is gestational hypertension. So what is gestational hypertension? Gestational hypertension also, the onset should be after 20 weeks of pregnancy, and there should not be any proteinuria or any other end organ damage or end organ involvement. So it is just a high blood pressure of more than 140 by 90 millimeters of mercury. The last one of this classification is eclampsia, wherein there will be onset of seizures, which is not explained by any other organic cause, or it occurs in a patient without any non-case of epilepsy, with a high blood pressure of more than 140 by 90 millimeters of mercury, with or without other features of end organ involvement. So this is a broad classification. So it is chronic hypertension with superadded preeclampsia, gestational hypertension, and the next one is a eclampsia. So there has been so many studies available earlier regarding any method for prevention and prediction of preeclampsia. So only the time-tested and evidence proof is available for one of these drugs, which is shown to have an effect in the prevention of preeclampsia. So the options are nitric oxide, calcium supplementation, aspirin, as well as heparin. So the answer would be low-dose aspirin. When we consider the other options like nitric oxide donors, progesterone, diuretics, low molecular weight heparin, the evidence shows that there is no use at all to prevent hypertensive disorders during pregnancy. What about aspirin? It's a time-tested drug, and there has been recent trials like aspirin trial also, which shows that it helps to prevent the preeclampsia in high-risk women. It should be prescribed at a dosage that is a low-dose aspirin. Dosage is from 75 to 150 milligrams of aspirin daily, and it should be started for prevention of preeclampsia from 12 weeks of gestation until the birth of the baby. Now, why this dose of 75 to 150 milligram? 150 milligram is usually indicated in obese women who are belonging to this high-risk group. So high-risk women includes if there is any history of hypertensive disorder of pregnancy in the previous pregnancies, any history of any chronic kidney disease, autoimmune disorders like systemic lupus erythematosus or antiphospholipid syndrome, type 1, type 2 diabetes mellitus, or chronic hypertension. In these cases, we need to start them on aspirin, even if one major risk factor is there. That is, these are all major risk factors. Now, there are something called moderate risk factors, but we need more than one moderate risk factor to start on aspirin, like nulliparity, age more than or equal to 40 years, pregnancy interval of more than 10 years, body mass index of 35 kg per meter square or more at first visit, family history of preeclampsia, as well as multiple pregnancy. So the multiple pregnancy and the age more than 40 years, all these have been recently added in the newer version of the guideline, or the updated version of the NICE guideline on hypertension pregnancy. Now coming to the next question. So which of the following factors can increase in preeclampsia? So going back to the pathophysiology of preeclampsia, we know there are certain imbalance which happens in the angiogenic as well as anti-angiogenic factors. So in normal pregnancy, there will be an increase in the angiogenic factors and decrease in the anti-angiogenic factors. While what happens in preeclampsia is the opposite. There will be an increase in the anti-angiogenic factors and decrease in the angiogenic factors. Now, what are the factors which increase during preeclampsia? So the options are soluble FMS tyrosine kinase like 1 factor, placental growth factor, PAPE, or none of the above. So the options, all these are angiogenic factors, and the answer is soluble FMS like tyrosine kinase 1. So soluble FM tyrosine kinase like 1 factor and endoglin, soluble endoglin factors, they are basically secreted from the placenta, and it usually increases in the maternal circulation even weeks before the onset of preeclampsia. And that can result in proteinuria, endothelial dysfunction, and other manifestations of preeclampsia. While the other factors, like the angiogenic factors, like the placental growth factor and the VEGF and PAPE, PP13, all these factors will decrease in preeclampsia. Moving forward to the next question. So it's a case scenario. As I've already mentioned, in part 2 examination, it's not only the SBAs with just numbers, figures, or percentages. You'll get even in SBS as well as more in EMQs, clinical scenarios, where we need to apply the clinical applied knowledge from the guidelines. 45-year-old woman is being induced for preeclampsia at 36 weeks of gestation, and midwife asks you for an urgent review as she complains of new onset headache as well as epigastric pain with vomiting. Her blood pressure was around 140 by 90 millimeters of mercury. So what will be your next appropriate management? So she is an advanced maternal age with a preeclampsia at 36 weeks and with the new onset symptoms of headache, which are impending symptoms. But the blood pressure is 140 by 90 millimeters of mercury. It's not very high, like in more than 160 or 110. Options are IV labetalol, IV magnesium sulfate, emergency cesarean section, full preeclampsia, blood profile. So while we analyze each option, so what is IV labetalol? So it is an antihypertensive agent which is used for control of blood pressure in pregnancy. Coming to about the antihypertensive agents in pregnancy, so it can be either oral preparation or intravenous preparations. So because if there is a hypertensive crisis or if the blood pressure is more than 160, 110 millimeters of mercury, then we need to use the intravenous preparation. Otherwise, on outpatient-based management, we can use the oral preparations of antihypertensive agents. Now coming to about the next one, intravenous magnesium sulfate. So one of the use of magnesium sulfate in obstetrics is for prevention of eclampsia. Also, it is indicated in severe preeclampsia, impending eclampsia. Emergency cesarean section, she might need an early planned delivery or an early emergency delivery, but at this point of time, she is having impending symptoms of eclampsia, so we need to prevent the onset of seizures. And full preeclampsia blood profile, definitely she would have gotten her blood investigations while she was seen before the start of the induction of labor for preeclampsia at 36 weeks of gestation. So now the best option would be to go ahead with the intravenous magnesium sulfate because of the onset of the impending symptoms to prevent the eclampsia. And she needs stabilization. If the blood pressure was persistently more than 160 by 110, definitely she needs an intravenous antihypertensive agent as well, along with magnesium sulfate. And magnesium sulfate has got the anticonvulsant action while it is not a antihypertensive. Moving on to the next question. Yeah, before moving on to the next question, I would just like to give you a brief idea about the antihypertensive agents which we use in pregnancy. So they are options like where we can give oral preparations as well as intravenous preparations. So the first line antihypertensive, according to the NICE guideline of hypertension in pregnancy, is labetalol. So labetalol is a non-selective alpha plus beta blocker. It can be started with dosages of 100 milligram twice daily, and it can be increased depending upon the blood pressure values. And the labetalol is not indicated if the woman is suffering from asthma or any other hypersensitivity reaction towards labetalol. And the second line would be nifedipine. Nifedipine is a calcium channel blocker, and it is a dihydropyridine calcium channel blocker. It can be started with dosages from 10 to 20 milligram twice daily to even 4 times daily. And one of the side effects of nifedipine is headache, as well as it can cause reflex tachycardia. So in those conditions, we need to have a judicious use of this nifedipine. And then the next available antihypertensive agent is alpha-methyl-dopa. Alpha-methyl-dopa, while we are using the drug, the important thing which we need to keep in mind is there is a risk of postpartum depression if we continue postpartum depression if we continue to use the alpha-methyl-dopa even beyond 2 days postpartum. So we may have to switch the antihypertensive if it is on alpha-methyl-dopa to labetalol or other safer antihypertensive agents. So these are the usual oral hypertensive agent preparations available. Intravenous preparations are mainly used if there is a hypertensive crisis or uncontrolled blood pressure, and they are IV labetalol. Then it can be sublingual nifedipine. The problem with sublingual nifedipine is it causes a sudden drop in blood pressure, hampering the uteroplacental blood flow, even causing a risk of sudden intrauterine fetal demise. So it is not advisable. So after IV labetalol, the next option available would be intravenous hydralazine. So that's a small idea about the antihypertensive agents. The next question, 25-year-old primey with severe preeclampsia at around 27 weeks of gestation, and she's delivered by emergency cesarean section. She's concerned about her future pregnancies, obviously about the risk of recurrence in future pregnancies. What is the chance of her developing preeclampsia in her next pregnancy? So is it 16%, 25%, 30%, 40%, or 55%? So the answer is 55%. So the NICE guideline also gives some tables regarding the risk of recurrence, as well as the other tables are regarding the indications for admission, or which are the scenarios where we can have an outpatient management, and also regarding the timing of birth as well. These are, I think, the 3 tables which are given the NICE guideline hypertension pregnancy. So if we analyze the table regarding the risk likelihood of recurrence of hypertension in pregnancy, any hypertension, the prevalence of hypertensive disorder in the future pregnancy for any hypertension, if there is any hypertension in previous pregnancy, then the risk is around 1 in 5 women. While if there is a preeclampsia in the previous or current pregnancy, then the risk of recurrence is about 20%, or it is also roughly 1 in 5 women. While if it is a gestational hypertension in previous pregnancy or current pregnancy, that is also roughly it is 1 in 5 women. So around 20%. So this is easy to remember. Like any hypertension, even if it is in the preeclampsia or gestational hypertension in previous pregnancy or current pregnancy, risk of recurrence is around 20%. Now, coming to about the preeclampsia. If any hypertension in previous or current pregnancy is approximately 14, it is 14% for preeclampsia. And for preeclampsia to occur in a previous or current pregnancy, for a history of preeclampsia is almost 1 in 6 women. So it is slightly less when compared to taking overall hypertension pregnancy. And if the birth has occurred because of the preeclampsia between 28 to 34 weeks of gestation, then the risk of recurrence is further increased to 1 in 3 women, almost like 33%. So if it is a preterm preeclampsia requiring birth, then the risk is increased, almost like 33%. All right. And if the birth because of preeclampsia has happened between 34 to 37 weeks of gestation, then the risk of recurrence is 1 in 4 women, or almost like 23 or 25%. Okay. Now, we'll just move forward towards extended matching questions. So extended matching questions are quite different from the SPAs. Like the clinical applied knowledge application, everything is almost the same, but we need to analyze them more carefully, and it will take little more time for answering compared to SPA. So always try to give more time for the EMQ answering. So the first question is 30-year-old woman at 36 weeks of gestation with a blood pressure of 170 by 120 millimeters of mercury with proteinuria has come. So usually the question would be, what will be your next appropriate management? And there will be a whole lot of options as well. So analyzing the question, she is like late preterm, 36 weeks, and she has got a blood pressure of 170 by 120, which is more than 160 by 110 millimeters of mercury. So that is preeclampsia with severe features, and definitely she has got proteinuria also. So she has got preeclampsia with severe features, and she is at 36 weeks of gestation. So these are all the options available, like whether we need to go for an ultrasound growth scan in 10 days, captopril, can it be given or not, Doppler of the umbilical artery every other day, emergency CAT1 section for the fetal indication, category 1 section for maternal indication, category 2 section for fetal indication or maternal indication, induction of labor, IV 500 ml of crystalloid, IV labetalol, magnesium sulfate, methyl dopa, nifedipine, oral labetalol, operative vaginal delivery, 2 doses of betamethasone, 12 milligrams 12 hours apart, or 2 doses of betamethasone, 12 milligram 24 hours apart. So what is the option which you would like to go ahead for answering this question? So definitely she has got a blood pressure of 170 by 110 millimeters of mercury. And so our priority would be to control the blood pressure. So we need to start her on intravenous labetalol, because yes, definitely she is at risk of having eclampsia, because severe preeclampsia is a precursor for preeclampsia. But along with that, we need to think about other complications, especially the complications of severe hypertension like intracranial hemorrhage, which has got a high maternal mortality as well as perinatal mortality and morbidity. So we need to control the blood pressure by starting with intravenous labetalol. And another thing is magnesium sulfate. Definitely in due course she will be required. But while we start on magnesium sulfate, we have to be cautious, because it has got magnesium sulfate is a drug which has got narrow therapeutic index. So the magnesium toxicity can happen very soon. Magnesium sulfate dosage, which is given for the prevention of eclampsia, is 4 grams of loading dose to be given over 15 to 20 minutes. And then it should be followed by a maintenance dose of 1 gram per hour. It should be continued at least for 24 hours after the onset of seizures if already eclampsia has happened, or at least for 24 hours after the delivery, whichever is later. And if in spite of starting on magnesium sulfate, if seizures has happened, then we need to repeat again a loading dose of 2 to 4 intravenous grams of 2 to 4 grams of intravenous magnesium sulfate. So while she is on maintenance dose of 1 gram per hour of magnesium sulfate, it is not routinely recommended to do the serum magnesium levels to check for toxicity, but we need to monitor the woman and look for her respiratory rate, whether she is having bradypnea with a respiratory rate less than 12 per minute, or urine output is going to the oliguric side, like less than 25 ml per hour or less than 100 ml in 4 hours, or if there are absent of the deep tender reflexes. In these conditions, then we need to be more cautious about magnesium sulfate. So only indication where we need to do the serum magnesium levels for the magnesium toxicity check is if the woman is having severe renal impairment. Now, moving on to the next question. You have decided to administer intravenous hydrolysine to a 30-year-old woman who has been admitted with severe preeclampsia for blood pressure control and planning delivery. So here this woman has got severe preeclampsia, and she is admitted for BP control as well as for delivery. And we are planning to give her IV hydrolysine. So what is the precaution we need to do while we think of giving IV hydrolysine? So IV hydrolysine drug is an arterial vasodilator, and it is a smooth muscle relaxant. So there can be a sudden drop in blood pressure when we give especially intravenous preparation of IV hydrolysis. So we should always be cautious. It is always better to preload the woman with crystalloids. So before you proceed with IV hydrolysis, crystalloid preloading is required as it is a vasodilator. And so the option here would be intravenous 500 ml of crystalloid, option I. Now moving on to the next EMQ. So the first question, she's a 36-year-old primary gravida at 32 weeks of gestation with a blood pressure of 144 by 90 millimeters of mercury, but no proteinuria. So here you can see she's 32 weeks and blood pressure is not in the severe range. So it is in the range of preeclampsia without severe features. But to tell it is whether it is a preeclampsia or not preeclampsia, either we need a blood pressure of more than 140 millimeters of mercury along with that proteinuria or an end organ involvement. Here she doesn't have a proteinuria. Then next thing we need to check whether she has got an end organ involvement or not. And also it is stated in the question that the blood pressure was 100 by 60 at the beginning of the pregnancy, like at the time of booking visit, and she feels well with no headache or visual disturbances. So there are no severe features as well, which we can pick up from the question. So either she is having like a gestational hypertension, which is without any severe features, or preeclampsia without severe features. But to differentiate between the preeclampsia or gestational hypertension, we need to do other lab investigations as well. So these were all the options which were given in this condition, whether we need to admit the patient to the hospital or whether we can do an outpatient management, or whether blood tests need to be done but monitor blood pressure weekly. The second option was do not admit patient to hospital or treat hypertension, but take blood test and blood pressure twice weekly, monitor it to be done. Admission of the patient has to be done to hospital and then start with oral antihypertensives, consider steroids and early delivery, though she is only 32 weeks of gestation. Option D was admit the patient to hospital and start on IV antihypertensives, very close monitoring of blood pressure. Option E was admit to hospital, treat hypertension with oral antihypertensive and blood pressure monitoring at least 4 times daily. Option F was admit to hospital, IV antihypertensives and very close monitoring, steroids, and think about delivery. Option G was do not admit to hospital, treat hypertension with antihypertensives orally, and blood pressure check at least twice per week and take blood tests. Option H was do not admit to hospital, treat hypertension with oral medication, and take the blood pressure at least twice per week. No need for blood tests. So what would be your option? So she is 32 weeks of gestation with blood pressure not very much high, and otherwise she is well, not having any impending symptoms or any signs and symptoms of preeclampsia also. So first thing we need to decide is whether she needs to get admitted to the hospital. Second thing is whether we need to start her on antihypertensives. If at all starting on antihypertensives, is it oral or IV preparation? And then whether we need to give medication, blood investigations for her, also whether we need to deliver her at present. So regarding the delivery, she is otherwise stable, blood pressure is not in the very high range, so she need not get delivered early. And as we are not planning for a preterm birth as of now, we need not administer antenatal corticosteroids also. The next thing is whether we need to start her on antihypertensives and whether it is oral or IV preparation. Yes, so the option here which we need to go ahead is she doesn't need any inpatient management. We can treat her on outpatient basis, but we need to start her on oral antihypertensives and blood pressure monitoring to be done at least twice per week and blood investigations also to be done. So this was another table which was given in the NICE guidelines regarding the recommendation whether a woman who comes with a high blood pressure needs to get admitted and what are the investigations to be done and how often those investigations have to be done. Now, regarding the gestational hypertension, so she is otherwise well without any signs and symptoms of preeclampsia. So this is a case of gestational hypertension at 32 weeks of gestation and blood pressure is less than 160 by 110. If the blood pressure for gestational hypertension is between 140/90 to 159/109 millimeters of mercury, then it is not required to routinely admit her to the hospital. And we can offer her oral antihypertensives if the BP persistently remains more than 140/90. And the target blood pressure to be aimed is 135/85 millimeters of mercury or less. And the blood pressure checking to be done once or twice per week until the blood pressure is in the target range. Whether dipstick proteinuria is to be done, yes, it can be done once or twice a week. No need to do routinely or daily proteinuria assessment. And that is one another change which is given in this guideline, as the management is not based on the proteinuria level, as well as it doesn't actually correlate with the severity of the hypertension also. Blood investigations we need to do at the first time of diagnosis. We need to do the investigations, a complete blood count, liver function test, renal function test, and then we have to repeat it every weekly. What about the fetal assessment? Fetal heart auscultation has to be done at every antenatal appointment. And the ultrasound, yes, we can do it at the time of diagnosis. And if it is normal, then we need to repeat it every 2 to 4 weekly or earlier if it is clinically indicated. What about the CTG? We can do it, the CTG at the time of diagnosis if it is in the range of antepartum fetal surveillance, and need to be repeated only if clinically indicated. So otherwise, for gestational hypertension, which is not severe, the CTG is indicated only in clinical indications. It is required only for clinical indications. Otherwise, it is not required. While what about the gestational hypertension with very high blood pressure? If it is persistent blood pressure more than 160/110, we need to admit them to hospital and offer them antihypertensives, preferably IV antihypertensives, IV labetalol. Target BP of less than or equal to 135/85 millimeters of mercury, and we need to monitor them every 15 to 30 minutes until the blood pressure is less than 160/110 millimeters of mercury. And for severe hypertension, it is advisable to daily do the urine protein analysis while admitted. And blood investigations are complete blood count, liver function test, renal function test at presentation, and also then we need to do it every week. What about the fetal heart? Auscultation at every consultation, ultrasound assessment to be done, and need to be done at least minimum of every 2 weeks as it is severe hypertension. And CTG to be done at diagnosis also, and to be repeated only if clinically indicated. Hope that's clear. Now, moving ahead to another scenario. She's a 27-year-old woman with 28 weeks of gestation with a blood pressure of 150/100 millimeters of mercury. At the beginning of pregnancy, it was only 106/60 without proteinuria. And she was started on oral labetalol and sent home to review after a week for a blood pressure check. At this time, her blood pressure was found to be around 167/115 millimeters of mercury with significant proteinuria and frontal headache. Also, she complained of flashing of light as well as spots in front of her eyes. So from the question, we are able to understand she's 28 weeks of gestation with a blood pressure, repeat blood pressure of in the very high range or severe hypertension. It has got significant proteinuria. So she is preeclamptic, and she has got severe features like blood pressure more than 160/110 and other symptoms also. So she has got preeclampsia with severe features. And what would be your management? Yeah, again, the same options. So definitely she needs to get admitted. The investigations need to be done. She needs to have a BP control with the initiation of intravenous antihypertension and antihypertensive agents. She is 28 weeks of gestation. So we'll just wait to see whether the blood pressure gets controlled with the intravenous antihypertensives. And in that case, if the blood pressure is getting controlled, no need to deliver her. So no need for antenatal corticosteroids immediately. But because she's having impending symptoms like frontal headache and flashing of light or spots in front of her eyes, she needs to be started on intravenous magnesium sulfate for the prevention of eclampsia. So here the option would be F, admit her, treat with IV antihypertensives, blood pressure at least 4 times daily, consult with an obstetrician. If persistently high blood pressure, then we can think of delivery. So this is a management for the preeclampsia with and without severe features. So preeclampsia without severe features is blood pressure less than 160 by 110. Then we need to admit them only if any clinical concerns for the fetal of the well-being of woman or baby are there. And there are prediction models available like the full PAES or the PrEP-S risk prediction models for preeclampsia worsening in pregnancy. Also, another thing which has been put forward in the guideline is the availability of the PLGF or the platelet growth factor, which can be done to predict the preeclampsia onset in the third trimester. So if the blood pressure is less than 160 by 110 and preeclampsia, offer pharmac treatment if the PP remains persistently more than 140 by 90 with a target blood pressure of less than or equal to 135 by 85. We need to check the blood pressure every 48 hours and more frequently if she is admitted to the hospital. Proteinuria dipstick checking only at the time of diagnosis we need to do and repeat only if clinically indicated. While we need to repeat the proteinuria assessment also if she has got any new onset signs and symptoms develop or if there are any worsening of the symptoms. And blood investigations to be done are CBC, the complete blood count, liver function test and renal function test. These needs to be done twice a week. In gestational hypertension, it was only weekly. Fetal assessment, fetal heart auscultation at every antenatal checkup, ultrasound to be done at diagnosis and then repeated every 2 weekly, CTG to be done at diagnosis and only if clinically indicated, we need to repeat it. What about preeclampsia with severe features? We need to definitely admit them and closely monitor blood pressure every 15 to 30 minutes until the blood pressure is less than 160 by 110. Offer the IV antihypertensives to attain a target blood pressure of less than or equal to 135 by 85 millimeters of mercury. And while the woman is an inpatient, we need to check the blood pressure at least 4 times daily once it falls less than 160 by 110 millimeters of mercury. Or if there are any new clinical reasons, we need to repeat the blood pressure then. What about dipstick proteinuria testing? We need to repeat it, do it at the time of diagnosis and repeat only if clinically indicated, unlike in gestational hypertension with severe features, where it is recommended to do the daily proteinuria testing to see whether she is progressing to have a preeclampsia with severe features. And the blood test, CBC, RFT, LFT to be done at least 3 times a week. Fetal assessment, fetal heart auscultation at every antenatal appointment, ultrasound at time of diagnosis, and minimum every 2 weekly if it is normal or earlier as it is indicated. CTG at the time of diagnosis and to be repeated if it is clinically indicated or any worsening of symptoms. So that's about some practice questions for the antenatal care module on hypertension in pregnancy. Yeah, regarding the timing of birth, preferable timing of birth for preeclampsia without severe features is within 24 to 48 hours once the 37 weeks have been completed. And if there are severe features, then beyond 34 weeks of gestation, we can consider delivery after a course of antenatal corticosteroids. Thank you.